This chapter here, urinary system. So when it comes to your urinary system, we cannot normally see it on a radiograph because of the atomic number of the soft tissue. So I think of the kidneys. You can see the kidneys here. The kidneys we usually see, right here's the right kidney, here's the left kidney. So we can normally see the outline of the kidneys on x-rays just because the adipose layer of the kidney and all that good stuff. You may have to bring it down too. You'd like to bring it all the way down. Because I know, because I was yelled at earlier. Other guys were yelling at
You
me.
had a bunch of females.
You drop that tube so I can see. Like, okay. They hit me in the back of the neck. But anyway, Serena.
They pre God avenge me.
See, yeah, it was a pre. They knew I was going to hit you, so I took it earlier.
Mm-hmm.
But anyway, so the bladder, the ureters and stuff like that, we don't see them. So the only way we can really visualize this stuff on radiographs is introduce contrast. And there's two ways we can get contrast into the urinary system. One is to pump it through the urethra. We call that retrograde. So a retrograde exam. And what that entails is putting a catheter, a urinary catheter, through the urethra into the bladder. Those catheters have little balloons at the end, so you pump up the little balloon with the little syringe so it doesn't fall out or anything like that. And then then they'll pump the bladder full of contrast. And it's a good study. It's actually called a cystogram. It's a good study because a lot of people end up with urinary tract infections. And the reason why they have urinary tract infections sometimes is maybe too much sexual intercourse that happens. But also sometimes the urine will reflux back up into the ureters again. And when that happens, it's not a normal flow and it can cause urinary tract infections. But it's just, that's not a very fun exam. I imagine somebody sticking a catheter through your urethra and then pumping you full of contrast. And then sometimes they make you pee. Okay, go ahead and pee now, and I'm going to take a whole bunch of images as you're peeing.
All the time.
I know, they're called VCUGs, voiding cystourethograms. But think of it as an adult. It's one thing as a child.
Right.
But as an adult, and guys, they give you a little urinal, they're like, okay, go ahead and lean over this way a little bit and pee for me. Everybody's just sitting there, and he's like all performance tower, ready to go, right? To catch you. But I thought, I don't know if I can perform right now, man. Everybody's watching me. Right? So it's tough, man. It's even for the babies, it's tough. And sometimes they get those babies and they don't want to pee, so they have to turn the water on. And
Yeah, they have to put water down their leg.
yeah, so they fill that. There's all kinds of different tricks they can do to get the baby to pee. But a lot of times they'll have a full bladder, man. They will not pee worth crap. But so anyway, that's called a VCUG. And the other way you can get into the urinary system is through intravenously. We don't do arterial sticks. We don't pump contrast into an artery. We put it into veins. Alright, so you guys will take a class this summer. It's an IV class. They're going to teach you how to start IVs and all the tricks and trades and all that good stuff. And you guys are going to poke each other. And then, so you'll get 2 sticks in there, and then you're supposed to get 8 more sticks on an actual patient in the hospital. A lot of times they'll say, hey, go over to CT, because CT they do IV contrast stuff like all the time. And they'll say, hey, go over to CT, they'll go over to CT, and you get all your sticks in a couple days. So, anyway, so intravenously, anytime you puncture the skin with a needle, it's a pretty invasive procedure. I would think putting the tip in somebody's rear end would be more invasive than that, but apparently it's not. Because you don't need an informed consent, to do BEs, but you do for IVPs. To me, that's way more invasive. But, but anyway, so when you have patients that they sign those forms, basically they're just stating that they understand the procedure, they've been explained the procedure, they know all the risk factors and all that stuff. And then they sign it and do the thing. Just because somebody signs an informed consent doesn't mean they don't have the right to stop in the future too. So you can't be like, hey girl, you signed that informed consent, that says go. You say no, I say go. Right? Because that'll get you in trouble, that'll get you a lawsuit. You're basically holding somebody against their will. Go in and get sued and lose their license and all kinds of other stuff. But those informed consents, if you ever look at them, they have specific ones for certain exams. And the IVP has, a lot of times it'll actually list all the different things that you talk about. You know, this may happen if you have this may happen if you have it, and this may happen. So it goes over like a lot of the mild reactions and side effects for IVPs. And there's quite a bit of them that can happen. But IVPs, again, especially with intravenous contrast agents, what you're doing is you're injecting iodine into a patient's vessel. Iodine has a high atomic number, which allows us to see the contrast. You can see the contrast on these images right here. So there's whiteness in here. That's all contrast. And the reason why we can see it is because it has a high atomic number. 53. There's 3 that you have to know for your national exam. One is iodine, which is 53.
56 and 74.
Barium, 56.
74.
And tungsten 7.
And tungsten, 74. Those are the 3 big hitters right there.
Oh no, people are loud.
I know, what's going on out here?
74.
And barium was 56. And then iron was 53.
It's Phil! Why is it always Phil?
He's trying to learn.
Phil? It's like your father. Phil!
People need a drawing on to play.
Poor Phil. That's why he has a hard time.
Trying to concentrate? She's got a pass.
So anyway, let's see. So contrast. So the reason why we can see is that the high atomic number, right? X-rays hit it, you get totally absorbed. What's that called when you get a totally absorbed X-ray? It's attenuation through what kind of interaction?
Photoelectric?
Photoelectric.
We just went over this.
Nice. The photoelectric effect. Very good. Good job, Jimmy. Got it, Phil. So anyway, so yeah, that was what allows us to see the kidneys, the ureter, the bladder, all that good stuff. And again, we don't normally see that stuff because of its low atomic number. Soft tissue has a really low atomic number. When you iodine, there's 2 different types of iodine. There's actually 3. One's called a low osmolality one, but there's 2 main types. One is an ionic type, and the other one's ionic type.
Non-ionic.
Non-ionic. Did I say?
You said ionic and ionic, and I was like, wait a second.
I just said ionic.
Ion or?
Am I going crazy?
Girl, you are. It's the mask. I said it. You just didn't hear it, right? It's the mask, man. It's the mask.
Oh my goodness.
Ionic and non-ionic. How's that? There's another one called low osmolar, but those are the 2 main types. The ionic, sorry about the 2, ionic and non-ionic.
Okay.
Okay, just worry about this.
For now,
On the written, no.
on a written no. But on the ionic, what happens is it has 3 iodine atoms. And for every 3 of those, 2 of them are able to pass through membranes and cause issues. So it's said to be hyperosmolar. passes through membrane very easily.
These are through can pass.
Through membranes. It's said to be hyperosmolar. So we call it, we say that it has a ratio of 3 to 2. For every 3 iodine atoms, 2 pass through membrane. That's considered to be hyperosmolar. 3 to 2. So what happens with iodine atoms when it gets into your bloodstream is it can cause problems. You know, our kidneys are basically a fancy filtration system. They filter out all the stuff in the blood that doesn't belong there. So you know when you guys like drink all that water and all this stuff, you've been drinking water all day. Your kidneys are constantly peeing, right? Like go in the bathroom every 30 minutes and it's like your body's like, hey dude, you don't need all this water, let's just get rid of it. So it's providing you with this, your bloodstream is equilibrium, right? And homeostasis and all this stuff. So it's taking out things that don't belong there. So when you inject iodine into the bloodstream, it's like, what are these things? We don't need these. So it's going to take out the iodine and put it in the urinary system and get rid of it, right? That's its job. Its job in life is to get rid of the iodine. And that's why immediately, once you inject that stuff, within a minute or two, you'll start to see the kidneys start lighting up already. So it happens like really quick. Super quick. But when you, if you're, since your kidneys are filtering this stuff out, what would happen if your kidneys don't work properly? And these iodine atoms, they stay in your bloodstream and they can cause all kinds of heart arrhythmias and all kinds of issues. It can cause kidney failure, liver failure, there's a whole bunch of stuff that can cause, kill the patient basically. So we have to make sure the kidneys are functioning properly before we even do these exams. Especially on elderly patients. Not so much on young patients, but the elderly patients, we have to get lab work done on them before they actually have this done. That lab work done is called a BUN, stands for blood, urea, and nitrogen. The BUN. And the other is the creatinine, or creatine. C-R-E, I think it's spelled C-R-E-A-T-I-N-E. What's that?
Sorry, it's C-R-E-A-T-I-N-I-N.
Oh, there we go. I forgot the I and I.
It's okay.
Yeah. Creatinine. Not the creatine, but the creatinine. So those two always go hand in hand. They're both basically check the kidney functioning. How well the kidneys are functioning. And specifically they check what's called the GFR.
Filtration, something.
Rates. Glomerular filtration rate. Because the filtration, all that filtration takes place in the glomerulus. That's that little bundle of vessels and stuff where the bone is trapped on it, absorbs it. So if those kidneys aren't functioning properly, we don't do the test. It's out of range. That test ain't happening. They are not getting intravenous contrast injection. They do this like a CT scan without contrast. Something different. So imagine if the kidneys aren't functioning properly and that stuff just stays in there. It's going to cause some serious issues. Some of the side effects that people have with IV contrast injections is sometimes they feel like a warm flesh feeling. I've had patients tell me that sometimes they feel like they wet themselves. They have to like literally feel like, did I just wet myself? Am I wet? Because I guess you just have this warm sensation down there. I've had people tell me I feel like they had an orgasm. I was like, wow, really? I'll sneak in a vial in my pocket. You had somebody tell you
I
that?
had a lady, she was like asking to go again because it felt like
Go
she had
again?
CT. Yeah, and I was like, what? It was weird.
Can I have, thank you, sir. Can I have another?
Seriously.
Oh my gosh.
She's a weird lady though.
Like, Yeah,
Shoot,
shoot.
I haven't had one in years.
What happened in 1 years? Yeah, so crazy stuff though. But another one is a metallic taste. And people, if you ever had like a blood in your mouth, you know, like you got hit in the lip or something, or you got like a tooth is bleeding, I don't know, something. I don't know why you would have blood in your mouth. Maybe you're like a vampire, right? I don't know. But blood kind of has that like a metallic, irony, you know, taste to it. Another common side effect from contrast injections is nausea and vomiting. I don't know about you guys, man, but when I vomit, that's a major ordeal. To me, it's a major effect.
That seems sucker check.
Oh, yeah. But it's normal. Another one is hives. What's the medical terminology word for hives? Like small hives, not like big.
Urticaria?
Urticaria. So like small hives. There's a table on page 541 that lists all the stuff that we just talked about. You know, they have on here too syncope. What's syncope?
Fainting.
Fainting, right? Now, I don't know, man. You know, when somebody faints, to me that's a pretty big ordeal. I guess there's a difference between fainting and being unconscious. Right? Unconscious, you can't wake them up, I guess. Fainting is kind of pass out. Like, oh, what just happened? So,
How people feel like that.
huh?
I said, I always wonder how people faint.
541. Yeah, I mean, there's a lot of people who have things that cause people to pass out. But,
It always looks so crazy, dude.
Yeah.
Drop like a fly.
sign of blood, yeah. Usually in their IV class, I usually have a student who I've had one, man, where I've had one that was sitting there, we were like watching them. I was like, oh, and he was like, oh. And he started getting, I was like, oh man, before I couldn't get to him, he was dropped, and the students like saw him dropping, and then they kicked the chair real fast. And he's like, boom. I was like, oh shit. Got a big old lump on his head. But yeah.
It has to do with the weird like vagus response. My girlfriend's the same way.
Yeah. It's what they call a vasovagal reaction. There's all kinds of, you know, even I've seen people, when you tip them, they pass out from a vasovagal reaction.
That wouldn't be so bad. Pass that one.
I
That's
know, they
happening.
heard.
For the patient.
I know, just leave them and just tip them real fast, they'll wake them up.
For the patient. Oh, if I pass down there, that is problem.
Huh?
Their muscles will relax. You don't want that.
Well, they shouldn't have anything in them when you're tipping
No, I'm
them.
just saying, like, you have to, like, experience it as a patient.
I've had people where I've taken staples out of their back. I used to work for a spinal surgeon sometimes, and there's big old long scars and all the staples popping them out and all pulling them out. All of a sudden I can feel them getting all sweaty. Like, what the hell? I was like, oh man, they're about ready to drop on. All of a sudden it's like gold minutes on the table. But yeah, so anyway, those are some of the common effects that people will see. And those are usually the things that you will see listed on the informed consent. So what you do is you like thoroughly explain the procedure to the patient, why we're doing this exam, and then you go over all the common side effects. Some of the moderate side effects are, it says severe, moderate to severe urticaria, laryngeal swelling, angioedema, hypotension, tachycardia, bradycardia. So those are some of the things that are a little more moderate that you have to really pay attention to. All the mild stuff that we first talked about, all that stuff requires is you just to calm the patient down and just to reassure them, you know, I'm sorry, this is happening to you, this is normal. Remember I told you this may happen. All this stuff is normal. And you always want to make sure too that you calm your patients down. Sometimes they go in and they're nervous when you tell them that they have to like get poked and start an IV, and all of a sudden some of this stuff can happen. So they start to get nervous and they start freaking out and panicking. You know, it never failed whenever I had like an anxious person. They always freaking are the ones that have a reaction. It's like, are you really? Okay, I saw this coming a mile away, man. People that are talking a lot, they're pacing, they're sweaty, and they're nervous, and always the ones that have reactions. And our jobs as technologists is to calm them the hell down. You know, relax. It's gonna be okay. Put your soothing voice on. It's gonna be fine. Help you get through this. No problem. You know, and you gotta calm them down. Otherwise, they're gonna just talk themselves into having what they call a psychogenic effect, and they just will talk themselves into having an anaphylactic reaction. It never fails. See it all the time. And let's see. So anyway, so the moderate stuff, basically, you just need to let a physician know. Say, hey, got a patient we're doing IVP on. That well, actually they know that we're doing IVP because they have to be there. They have to be in the department. But you gotta let a doctor know that the patient has hives. Hey, just let you know, we injected this patient. It's been 5 minutes. It's starting to break out in hives. Just a FYI, let you know if anything gets any worse. And just so they're aware of it. That way they can be on alert if something does happen in the future. So it doesn't require like immediate attention with the moderate effects, but somebody has to be told what's happening. The severe stuff is listed on here. Hypotension, and then it even gives you like a systolic pressure less than 80 and all this stuff. Bradycardia, no detectable pulse. That basically means your patient's dead, right? That's a pretty major reaction. Patient dead. They dead.
What's happening?
Laryngeal swelling, convulsions, arrhythmias, respiratory. There's like a whole bunch of anuria. Anytime you see A in front of something, that means like a total lack of. No pulse. Again, they're dead. Seizures, there's all kinds of stuff. Those require codes. Okay, you hit a code button or you call a code, whatever it is. Right? What's the code for a CRMC? Not 777. That's payday, right? Clock it in?
Yeah, let's clock it out.
I'm all.
You hit the code button and you go
Well,
back to the
CRMC, I
CPR.
don't know.
Oh, there's a code
There's
button?
a code button on the wall.
There used to be like some kind of a download.
There's a
You
code
dial
button.
18.
Code blue is.
You dial 18 and then you tell them where it's at.
Right.
And
Or
code
what
research
room?
in the.
There's buttons.
Yeah.
Most rooms have buttons.
Yeah.
Most
But
rooms
if
would
they
have
don't,
a
you
code
don't.
button. But some hospitals, you dial a number. 2218, what is it?
18.
I thought it was 222 for CRNC.
That might be 22. I used to work at CRNC and I was.
Probably.
I just remember 777. That's pocket. That's
They
money
just
right
turned that
there.
off last year.
I just know how I was getting paid, and don't ask me to call a code. I don't know that one. But but they bypass like all the other calls, and you just tell them, and then you hear them over the intercom. Radiology, code blue, radiology, room 2, and they'll repeat it a few times. But that happens. You said it happened to you.
They knew the patient had already coded earlier, but the doctor wanted to CT with contrast, and he said, do it anyways.
Shit.
So the nurse, we put the patient in the machine, gave him the contrast, and when he came out the machine, the nurse like, what does the monitor say? Flat line. So we went in there, we started CPR, and then they called the code overhead, and then the ED came and took the patient on.
Yeah. It happens.
That was the second time.
It happens, you know, when you give contrast injections, intravenous contrast injections, there's always that chance of your patients going down. And I hear every year, I've had that in me one time, you know, where I had a patient like, really, on my freaking shift, are you kidding me? The patient was like talking 1 minute, and I looked up and they were kind of blue, I was like, oh, hell. And before I can get to the code button, they were already out. And I was like, that was like super fast. Usually when people go down or they have issues, it's normally within the first 5 minutes after injection. So it usually happens fairly quick. Not to say that it doesn't happen later too, but normally most of them happen within the first 5 minutes. And I remember giving the patient CPR and doing chest compressions. And, you know, back then you're supposed to do like 2 puffs for every 15 compressions. I was like, I'm puffing on nobody. I like to do chest compressions. I remember doing chest compressions and the freaking code team came, like you said, they worked on and they were putting the gurney and swooping off and it was like, man, on my dime. It's only happened once to me, but I hear students every year that say, hey, Mr. Oaks, we had a patient code on us, because we gave him contrast. It happens like every year. So it's going to happen to you guys eventually. If you are in the field long enough and you're doing enough of these exams, IB exams, it'll happen.
Yeah, I feel like I'm gonna be like, oh, good, somebody help.
The techs came in and they left. The other transporters came in and they just like, yeah, you're doing a good job. And then they walked out.
Don't know.
Like your wife's position, you got it.
So it sucks, but it happens. And that's why we always stay with our patients. You never leave an IV patient. And you're always supposed to have a physician in the department. When it happens, you must have a physician in the department. Like those imaging centers, we have like FIP and AMI, and there's a whole bunch of those little small imaging centers. They do all these contrast injections too, but they have to have a radiologist on board. About 15 years ago, man, there was a group of physicians down south in the Hanford area, and then a group of imaging centers. They got fined by the state because the state was doing like surprise site visits, and they walk in like at lunchtime, and here's a CT tech, got an IV contrast CT going, and they're like, hey, where's your radiologist? Oh, they're here at lunch. It's like, you don't have any radiologists on staff right now? No, they all have to take off at lunch around 12 o'clock. They're usually back by 1:30 though. I was like, ooh. You cannot do intravenous contrast injections without a physician on site. They have to be on site. So it's like a big no-no. But again, you guys will take that class in the summer. You guys will be, that's our job as technologists to start IVs for contrast injection only. We don't start IVs to push benzene and stuff like that.
Do you want to know this on the written test?
No, you know what? There's a lot of pages. There's a few pages on how to start IV, and it talks about the whole technique and cylinder technique and all that stuff. Don't worry about it. I don't have any IV questions. I would maybe know what's the most common vessel that they use and stuff like that for IV contrast injections. But the technique and all that stuff, don't worry about it. There's no question on that. That's it. That's all you really know, major vein. And maybe know too that smaller gauge needles means bigger lumen. I would know that too.
And again, all the CT stuff, don't worry about it.
No CT stuff. Not unless there's a pathology that's better demonstrated in CT, like previous chapters. But so anyway, so that's just keep an eye on your patient. Never leave it. If you have to take off, go to the bathroom, call somebody. Call transporter, call somebody. Hey, you might hang on this patient. Tell them what you just did. Don't tell them, hey, I'll be right back. Just say I just injected this patient with IV contrast. I'll be back in 4 minutes. Whatever it is. But never leave a patient. All right. So those basically, some of those are what they call anaphylactic reactions. And anaphylactic reactions are just basically allergic reactions. People have allergic reactions or anaphylactic reactions to all kinds of different stuff. Food, anybody have any food allergies in here? No food allergies? Bee sting allergies, you get people.
Red ants.
Huh?
Red ants.
Red ants? They cause hives?
Like a deep swollen eyes,
Yeah.
deep swollen, big old welts and stuff.
Yeah, so that's urticaria, right? And that's an anaphylactic reaction. So people they can have a reaction to all kinds of different stuff. Food, plants, ants, bees. What's that?
My girlfriend, she gets looked at a mosquito and told her, you need to waltz. It looks like I'm beating her, and I'm like, we're just going for a walk in the evening. Just home, and it was just crazy. I'm like, what the heck?
can be long too. Sometimes I get big.
So like we'll go for walks and like summer nights and she's all like along stage and stuff, and they'll still go through the clothing and it just
They like her.
Mm-hmm.
Crazy.
Feels like whole blood.
right.
You're like, what?
It's like old.
I wonder what my husband is. Because we'll be sitting right next to each other. I won't get big.
Yeah.
He'll be all tore up.
I read up on it because I've noticed like every time my husband and I go out, I always get bit, but he like has like one or two but out multiple.
That's fine. So like, Dennis was no good, don't bite him.
Yeah.
So anyway, so IV contrast, that's basically it. Now there's another type of contrast that's non-ionic, and it has a ratio of 3:1. So for every 3 iodine atoms, 1 may pass through and cause issues. I had a student come to me once and say, "Hey, Mr. Oaks, I graduated, took your national exam." So like, I took the exam yesterday, and then there's a question that asked if non-ionic contrast agent does it have iodine in it? Because non-ionic, right? You would think that it doesn't have iodine in it, right? But how would it show up on X-ray if it didn't have iodine? Right? It has to have iodine. So don't let the name fool you, non-ionic. If it doesn't have iodine atoms in it, it ain't showing up on X-ray.
It looks like it contains non-positively charged cation.
Cations, yeah.
They're not showing.
But it has iodine in it. It has to otherwise. It just has a 3:1 ratio. For every 3, it gives up 1.
And you're talking about atoms, not.
Yeah, exactly. Yeah. So nothing there is going to say that it doesn't have any iodine in it. So I think what they meant by non-ionic is it doesn't have a lot of the qualities of ionic. So there's less of the mild or moderate reactions, which is true. There's a lot less reactions just because of the 3:1 ratio. And I don't even think too many people even use ionic anymore. They used to use a lot of ionic contrast. But I think most places they use non-ionic. So again, it has iodine atoms in it, and if the patient's going to have a major reaction, it doesn't matter what you give them. They're going to have it no matter what. You have a question?
Yeah, how common are these breast cancer?
Not very common. Basically, CT scans. They're like the modality of choice these days. So they're not very common. We used to do a whole bunch of them, but we just don't see them very much anymore. But you may do some, I don't know, you may not. Who knows? But not very common. Let's see here. So contrast, let's talk about getting contrast into the vessel. There's 2 ways you can get contrast into a vein. What normally we'll do is we'll take a bottle of ISOVU and we'll put a needle on a big 60 cc syringe, and we'll suck this contrast out into the 60 cc syringe. And then we hook it up to the patient's IV and we push it in. And this is called a bolus injection. Anytime you rapidly push the contrast into a vessel, it's termed bolus. Like the CT injectors that you guys see, those are really quick, rapid injectors. It's a bolus injection. That contrast is very viscous, it's real sticky, and it's not easy to push. I see some people, they're like, oh, they're shaking. Sometimes they'll put it against their hip.
Is that why it helps to warm it up?
Yeah, it's because it's less viscous, it's less sticky.
Yeah.
Yeah, it's less sticky. So it's not easy to push, especially when you have a small needle. When you're having a small needle or a small catheter. So a lot of times it's just not very easy.
So why CT? Sorry.
No, it's okay.
If the patient has like a port for like a
Go
chemo,
for it.
it has to be a specific port and a specific needle combination, or else they don't give it?
I don't know about the ports. I'm not too familiar with why they do what they do with the ports.
So when they give a contrast, I noticed that there's specific ports that they have to use, and sometimes they'll X-ray the patient in chest X-ray, like an AP, and then there's like a number or a designation on the port, and you can see it in the X-ray. And I know there's a specific needle that they have to have hooking into the port, or else they don't.
I don't know. I don't know much about the ports. But sometimes those ports are like they're central lines, and sometimes they're like Swan-Ganz catheters where they go into the artery. But, huh?
Like an EJ?
Yeah, but it goes into the artery though. I don't know. But yeah, I never really dealt with any port patients, so I used to do CT scans. But the contrast was always tough to do sometimes. And then you can drip it too. A lot of times you'll get these bottles where you can hang them upside down from the IV pole. Or they come in sometimes the contrast will come in little baggies. Like it's almost like the lactated ringer bags, little itty little bags. But sometimes you see medication that they're dripping into somebody's IV in a little bag. So they're very similar to that, where it just drips, and those are called drip infusion. So bolus or drip infusion, as usual, how we get into patients. Bolus is the most common because you're pushing a large amount of contrast really quickly into the patient.
It is the most common.
It is the most common. And when you push it in quickly, like a large amount fast, the kidneys are going to take in, they're going to highlight really quick. And you're going to see the renal pelvis is fill up really fast. So it's everything just happens in large amounts. But if you're like dripping it, it's going to be like really slow. The kidneys are slowly taking in and slowly getting rid of it. And things really don't, like the renal pelvis really doesn't fill up like it should. So dripping sometimes is no bueno. You see this x-ray, let me show you this x-ray right here. See this little thing here? You see these little two round things? This is usually what they use when they do drip infusion. These are called ureteric compression devices. And these are they're two little balloons, and each balloon has a little tube that connects to one of those blood pressure cuff things. And you squeeze it, got a little thing where you tighten it and you pump it in, and it's full of air. So what happens is they place them just on either side of the spine at the ASIS level, because that's where the ureters come down off the kidneys. And they'll place them there. They're not inflated yet. They're deflated. And then they have this plexi-board glass. It's hard. They'll put across it, and then they'll put a belt around the patient. They'll strap it on. So it's kind of putting pressure. And then what they'll do is they'll pump up those bladders, so it's applying pressure in that area. And it's keeping the contrast from draining all the way down into the bladder. So you can see the contrast kind of stops right here and right here, right? So that compression is keeping it from draining into the bladder. So what happens is the proximal uterus, the renal pelvis, and the calyces, they all fill up really nice. So you can see them a lot better. So a lot of times when you do drip infusion, you'll see some techs that will use compression devices just so they can fill all that stuff up. And they'll take x-rays of the kidneys like this, and then they'll release the air in the bladders and take them off, and then it just rushes down into the bladder, and then they take all kinds of ureter shots and other stuff like that. But these exams too are all timed exams. You can see here. See how that's 5 minutes? I think it's 5. That's 5 minutes right there. So this is very similar to like we did with the small bowel, the last chapter. This is a functional test. This tells us how the kidneys work. And it also tells us, it shows us if there's any obvious pathology and stuff like that. But every image we do, we have to label the time on it that it was taken after injections. And that kind of depends on the hospital and the protocol. Some hospitals, they require, they'll tell you to do like an immediate film after injection, and then like a 5 minute, a 10 minutes, and then they'll have you do like a 15 minute, including the obliques, and then maybe like a 20 minute or something like that. Then they'll have you show the doctor and tell you if there's any other things that they want. But they're all timed, so you have to have the time, you have to have a marker, you have to have all the stuff on there. Let's see. So let me ask you a question here, you guys. So if we had, now that we're going through all the contrast stuff, if you had a patient who required a upper GI, a BE, and an IVP, and you had the task of scheduling this, how would you schedule it? Which order would you schedule them in? So you need an upper GI, a BE, and an IVP. And the national exam is famous for asking this question. Huh? That's exactly right. You always have to think about the exam that's going to get rid of the contrast the quickest. IVP, when you're injecting the patient with contrast, it'll be in your kidneys, it'll start showing up in your kidneys in less than like a minute. And at 5 minutes, you can see where it's at, right? At 20 minutes, it's all basically just drained from your system and sitting in your bladder already, waiting for you to pee out. So it's a quick exam, man. That stuff gets in your system like super quick. What exam next would you get rid of the contrast the quickest? A BE, right? Because we tip them and they poop it all out again, right? The upper GI is the one that's going to take some time to get through the system. And sometimes it stays in your system for a long time. It just depends on how much water you drink. So you always have to think about with scheduling, which one would you get rid of first? And that would be the IVP.
The remnants from the IVP on the BE would be so far up or in the bladder.
Yeah. And you have to think of this too, if you did an IVP after a BE, you're still going to have stuff in the colon. And it might be hiding, and you can have stuff in the colon for like, I've seen people like a year later and it's still stuck in the colon. It's still stuck in the hospital. You have a question?
Yeah, but I'm sure there's something you could do, but like, with a scheduling question like that, are we only focusing on what's in the first, or should we, like, other variables like NPO or that's not
Well, that'd fall under the realm of priority scheduling.
okay.
Yeah. And these patients all are priority scheduling too. Because these patients are all NPO too. But when it talks about just like scheduling in general, which one would you, patients got these 3 exams. Well, basically all 3 of them, they have to be NPO for 8 hours anyway, right? So you just have to think about which one would be contrast to leave the body the quickest. But when you talk about priority exam, you're thinking about the really young or the really old are always the ones that get scheduled first. And the ones that are sick, super sick. Those people that they're physicians, you need a BE, and they're like, in their 40s and stuff. Guess what? Y'all are getting pushed closer to lunchtime. So, that's because of the other patients. It's almost like triaging, Let's see here. You can see the psoas muscles too in this X-ray. See the psoas muscles right here, and then you can see the other one right here. So remember, the psoas muscles, they connect to like T12, and they go all the way down to the lesser trochanter of the femur. They're very posterior. They run just lateral to the lumbar spine, so they're way in the back. The kidneys are also way in the back. They're retroperitoneal. So they're very posterior too. And how they lie in your body is they lay way back over here, but they lay like this. Like this, right? Go way back here. And more, I think, on each side of the spine, as you can see. And this portion of the kidney, this area right in here, it's called the hilum. Just like the lungs have a hilum, there's a hilum of the kidneys too. Hilum is where the blood vessels go into the kidneys. But this medial portion of the kidney and this medial portion of the kidney right here, you can see it's kind of resting. It looks like it's touching the psoas muscles. And it's almost like using them like pillows. And the reason why they sit like this is because the middle portion of the kidneys are sitting on, they're resting on the psoas muscles. So that's what's causing them to do this. So that becomes important when we start talking about the obliques or positioning. Because if you want to see a kidney, our job is to put it parallel to the image receptor, right? That way it doesn't look like it's foreshortened. So if I were to see the left kidney, I would put the patient in the RPO. If I was to see the right kidney, I would put the patient in the LPO. And what happens with the LPO is you can see the right kidney in profile. So now it's parallel to the IR. But as ureter comes down, it goes right over the spine. So we can't actually see the ureter of the right kidney. But what happens is the left kidney actually gets thrown away from the spine, so we can see that a lot better. So when you do the obliques, you're like an LPO will show the right kidney, but the left ureter. So we're always looking at the opposite ureter. If you're to put the patient in an RPO, it's going to show the left kidney, but the right ureter. So we're looking at the upside kidney, downside ureter, basically. If that makes any sense.
Oblique shows your oblique shows the opposite to
What's that?
the oblique show the opposite ureter.
Oh, the kidney scene, yes. So if we're looking at the right kidney, the opposite is ureter.
So you said LPO, you see the right kidney and the left ear?
Yes.
That was the right kidney.
Is there a picture of it?
It just is labeled like elevated, that's demonstrated.
Oh, the elevator side, demonstrated side?
Yeah.
The upside, basically. The demonstrated kidney side.
Right, and then that's demonstrated on the ureter. Like, on the downside.
Oh, okay, yeah, that's correct, yeah.
And then like an LPO, we're looking at the left ureter.
Correct.
Is that going to be, that's going to be on the right side of the spine?
No, I'm in the left side is fine.
Yeah, so you're looking at the right ureter.
Well, it's still on the left ureter is still on the left side. I mean,
So it isn't totally on the other side of the spine?
no.
Okay.
But you're doing an LPO is taking the right ureter and it's throwing it on the spine.
Parallel, okay.
It's throwing it over the spine. That one's it's heading to the left side, but it'll literally be like right over the spine. And they normally sit like this, like a 30-degree angle. That's why we do 30-degree obliques. Let me get that part. Let's see. What other stuff do we have? So this exam, though, it's very similar to like a small bowel fall through. We do the whole exam by ourselves. We just call your patient in, get them dressed. They have to have everything taken off with their underwear. And when you explain the procedure to the patient, why we're doing, I always tell my patients we're doing this IVP because not only did the physician order it, but we cannot see the urinary system on plain x-rays unless we have a contrast inside of you. And the only way we can see those and get that contrast in you is to do an IV, an intravenous injection. And a lot of times, even when you tell patients when they're doing an intravenous injection, they still don't know what the hell you're talking about. It's like, who and the what? Especially the older patients. Intravenous, what? What the hell is that? What does that mean? I need to poke your vein and push contrast, some liquid stuff in your body. You need to really dumb it down for people.
Yeah, you never know when
Yeah.
we tell the procedure that you under and stuff like that. So we had a lot of people understand what was going on.
It's funny. It's funny because you would think that the patients, like physicians, would tell them too. But they don't know. People are like, oh, I have like back pain and it hurts right here and I have blood in my urine and doctors go, let's go get an IVP. I'll schedule for an IVP. They'll call you and they'll set it up. Have a good day, and they walk out.
Yeah.
Yeah, that's usually.
I got a date, get an appointment.
Yeah, that's usually how it is. Because they're like, you know what, my job isn't to explain the procedure to you. That's somebody will do that for you. But it would be nice if they kind of had a heads up.
Yeah.
You know, I mean, that would be a good physician or a good nurse practitioner or PA or whatever to say, hey, and in order for us to really get a good look at your kidneys, we need to put some contrast in there. You can't do it here, so we'll have to schedule you. But let me just tell you what they're going to do. They're going to put a little needle in here, and sometimes it's in the hand, and they're going to put the stuff that's going to, make you feel warm. And it would be nice if they had a little knowledge about that stuff. A lot of them don't, though. A lot of them don't. They just know that, hey, I need an IVP. And most of them even do know, but they just don't care to explain it because they have patience. Time is money. Right? Time is money.
10 minutes, 15, see you later.
God forbid if you spend too much time with somebody because that's money. Especially doctors are the worst. Doctors are the worst. Nurse practitioners and PAs, they'll spend a little more time with you.
Yeah.
But that kind of depends too. There's some really shitty nurse practitioners and PAs too. But it just kind of depends on who you deal with, But it is what it is. It's just like there's some really shitty extra techs too, right? Shitty people all over the place.
That's what Oaks
No, it's
were,
a uniform
say,
activity.
like, even if you're, you should do like, whatever. At the end of the day, they'll
Yes,
send
sir.
them.
Oh yeah. That's what they always say. You know what they call a doctor who graduated at the
Yeah,
lowest,
the lowest score.
at the lowest class.
Who?
They call him a doctor.
Yeah, that's what he was telling us.
Yeah, and it's true. I get students that graduate and like, good luck, man. You squeak by the hair on your chinny chin chin, and you are not a good student. And they end up getting jobs, and this, they're the ones out there that have issues, and not very good, whether it's an attitude issue or whatever it may be. But you guys see them out there. How many techs have you seen already that you worked with that are either no good, or they have shitty attitudes and they're mean, or they treat you like crap, or they treat the patients like crap too. I see people text like, yanking patients around and talking to them. It's like, oh my God, what is wrong with you, man? You got a freaking job. You better be thankful if you even have a job. So that's the same thing that they were going to do. It's the same thing. How many bitter ass nurses do you see out there, man?
Oh my God.
Yeah.
Good Lord, have mercy.
I understand they got it rough, but still, it's
Bitter nurse.
They chose that.
Talk to A, man. You talk to A. A freaking made me laugh one time. I always ask, sometimes I'll ask kids, hey, why do you want to be a tech? I don't want to be a bitter ass nurse. We got some bitter ass nurses. I never forget what A told me that.
He's
man.
on.
Huh?
A?
Yeah.
From Clovis?
Clovis.
Yeah.
Bitter ass.
I do.
Bitter ass nurse. That was a lot of good.
actually a good example, good excuse. I like that.
Yeah. Too many bitter nurses already.
Oh, you're doing that, you're doing that fast.
I don't know what it is about nurses. There's not all of them like that.
No.
But there's that old saying that nurses eat their young. Because they're just like, that's just some crazy. And I don't know what it is too. The NICU. The NICU is like the worst. And they're like territorial, and those babies are like theirs.
And that,
CBIC?
Huh?
CBIC?
Oh yeah.
oh yeah, but the Valley, all those people are so nice.
Really?
They are so nice.
They're protective, but they're nice.
Yeah. But
Or
then
more
at
like-
Fresno, they're like,
Close to the sterile field,
you're like,
downtown. Well, I was at a nurse deck.
Oh,
I got the
okay.
machine real close. Touch the sterile field.
hey, I'm not doing anything.
me and Jesus had an issue with the portable machine. Oh my God, these nurses were all staring at us. Like, I'm like, your doctor ordered it wrong. Like, there was no accession number. There was like, so we couldn't shoot.
Yeah, first one, they're like, don't hover over the baby. It's like, well,
How am I supposed to take this?
You see the machine, it hovers.
It's gonna hover. So anyway, yeah, so wow. What we got? We got subject here.
That's nothing new.
Let's see, so IVP, so anyway, we talked about some of the positioning and stuff. There's also a procedure for IVPs called a tomogram. I don't know if you guys ever heard of the phrase tomogram before. But a tomogram basically utilizes motion to blur structures out above the interest and below the area of interest. So what you do is you're here in the show. You have to have a room capable, first of all, of doing tomograms. So what happens is you just center on the area of interest that you're looking for. So let's just say we were like centering on the kidneys and all that good stuff. And when you line up the bucky to your tubes like you normally do, when you hit the tomogram button, it connects the bucky and the X-ray tube together. So now they're like talking to each other. And what happens is when you go down halfway on the prep button, you're gonna see your tube do this. Like that. It'll stop right there. So you're still on the prep button. And what happens when it does this is the tube goes over here. So they're always still lined up with each other. It's like talking to each other, right? So they'd be still lined up. And when you go down all the way in the exposure button, it's going to go and stop. And then go back to the normal spot. So the whole time it's doing that is the bucky is going in the opposite direction. The tube goes that way, the bucky goes this way. It goes this way, it goes that way. But they're still always lined up. So what's happening is you have this one area of interest that's nice and clear, it's in detail. We call it the fulcrum. The fulcrum, what you do is you set it on your control panel usually, or you can set it on here. So sometimes I have buttons on here. And let's say you want it like 10 centimeters. So you put this thing on 10, and what it's doing is it's taking 10 centimeters off the table, and the X-ray beam is passing through that area, constantly passing through the same area as it's moving. But areas above it and below it, the X-ray beam is going through different areas, and it's throwing all this different stuff all over the image receptor. So basically what it's doing is it's utilizing the theory of motion to blur structures above that area of interest and below the area of interest. But the area of interest, again called the fulcrum, is always nice and clear. It's crystal clear. So again, it uses the theory of motion to basically take all of that, the structures, and blur them out. So when you look at,
You have to measure the patient to get the picture.
you do. Yeah, you have to take the calipers, you have to measure the patients. And usually the kidneys are like 8 centimeters, 9 centimeters above the table for like a normal average sized patient. What they do is they measure the patient, and there's like a calculation they do to figure out which cut to do. But we as techs will do a scalp film, like an 8 or 9 centimeter scalp film, and we'll show the radiologist. And the radiologist is like, okay, yeah, that's pretty good. Do a 8, 9, and 10 centimeter cut to the patient. So we'll either do 8, 9, 10 through those kidneys. But it does require the measurement of the patient. And I actually have a video of it here. See this particular tube here, there's you can see like a 9 on there. So that's like the fulcrum right there. So she's set in the fulcrum. And she's got her cute little calipers. You guys see me use those in class, right? So they're measuring the patient. I don't know what she's saying, but she's probably talking about how to, take the measurements and figure out where the kidneys are and all that stuff.
Do they usually just do this for kidneys?
No, they can actually do tomograms. We used to do them for TMJs. We used to do them for the odontoid process. We used to do them for the sternum. We just have the patient just lie flat on their back and do them for like sternums instead of doing an REO. We used to do it for wrist X-rays, all kinds of different stuff. But CT, basically took the place of all that stuff. So she's just setting the fulcrum, and again, that's the area of interest. So everything above 8 centimeters and below 8 centimeters are going to be blurred out. And so she's going to go back over here. She's going to hit the prep button and watch the tube. And when she goes all the way down the exposure, it'll move the other way. See, there's a prep phase. You can see the bucky moving. And now she's exposing. And see the bucky moving the other way? And then it goes back to its regular spot again and it's over. So it's just a theory of motion. It's just blurring. It's almost like orthostatic gradient. It just moves everything and blurs it out of the way. Not all hospitals have these fluoro machines like this. And again, it's just a regular old X-ray machine, but it just has tomo capability. If you go in the hospitals and you look at your control panel, some of them will say tomo. It'll be like an old tomo button. And if that's the case, then it has the ability to do tomo. But it's pretty cool though. I used to do them all the time. I used to love it. It was pretty cool. And the images look like this. You can see how it's kind of fuzzy, it's kind of blurry to me. But when you look at the renal pelvis and the kidneys and all this stuff, they're actually like super clear. And you can see the spine is pretty clear. It's because actually it's better on my computer. Sorry, man.
Are you using this again?
No. But you can see like the outer margin of the kidneys and the KSCs are, pretty darn clear. But what you don't see is like intestine. You don't see any gas. You don't see any structure that you normally see that's on top of the kidneys. So that's kind of like the beauty of it. If you go down here, I can see this image down here. See how you have all the gas and the poop and all that stuff? But you don't see it on here. That's because it's using motion to take those structures and throw them in different areas as it's moving. And it basically looks like it's fog that creates the motion. Pretty sick though.
So that just allows you to see like a whole kidney at the border and like what they do on that and do.
Well, what it's doing is it's giving you like a thin slice of the kidney, like a section of the kidney. So imagine me holding the kidney like this, and imagine this area is like 8 centimeters in here. So we're just looking at this particular area of the kidney.
It's blurring the top and bottom.
That's blurring the top of the kidney and the bottom. So yeah, everything that's not within that 8 centimeter spot is getting blurred out.
You're trying to get exactly in the middle where the high one.
Yeah, you're kind of like, if this is the kidney, you kind of want to go like boom, boom, boom. You want the middle parts.
Okay.
Right? Makes sense? And that's usually the doctor will figure out. He'll look at that and he or she will be like, oh yeah, that's a pretty good slice right through the middle of the kidney. I can tell you're in the middle of the kidney. So let's give me, if this is 8 centimeters, why don't you give me like a 7, 8, and a 9 or something? Yeah, so that's what they'll do.
So even the scalp is with the motion.
Yes. Well, we normally do a plain one and then a scalp. So we show the doctor all the different scalps. Yeah. But definitely you will do, if you do tomograms, you have to do a scalp with the tomo before you even inject the contrast. That way they can figure out what slices they want to see, which focal level they should see. All right, you guys have any questions with that?
Is that going to be in the test?
The tomogram? I don't think so. It's in the book.
55, 55?
If it's in the book, it's probably more than likely to be a test.
You said that, but we're not doing anything about
Nephrogram versus nephrotomogram. I would at least know what it is. It uses motion to blur structures out. Yeah. I would definitely know what it is. But make sure again when you have these tomograms, not only do you have to put what time it was taken, but you also have to put the focal cut, the level. So if this is like, let's say this is like an 8 centimeter cut, they don't have it here, but usually you would put it like down here or put it up here out of the way. I used to put it right in the middle of the spine. We used to have lead markers, like 8 centimeter markers, 9 centimeter markers.
The picture in the book shows it.
Oh, does it show it right in the spine?
Right on the spine.
Oh yeah, that's why I used to always put it right in the middle of the spine. Because there's really nothing of interest that we want to see there. So I used to stick that sucker right in the spine. Alright, so let's do some positioning. Now the positioning test is really easy. It's going to take you about 5 minutes. So if you guys want
Can you do it today then?
Do you realize every time you say
Yeah,
that,
it
it
takes
backfires on
forever.
you?
It's the first class, man. It's the first, the damn first class
Well,
always
then
slows
you
me
need to open
down.
up 2 rooms.
You've been to first class.
No.
I gotta do
Been
like 5
4
hours.
I know.
4 hours.
Like scared to say.
And I think that happens is you guys have waited so long, you're just like, oh, screw this shit. I just want to test and get it out of here. I'm tired. I just want to be done. So they go, boom, 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 I'm done.
Well, why can't you just let the people who want to test first just test? Yeah. They made it to where like they didn't want to test and we had to wait because they wanted to test.
Well, it wasn't part of the class time yet. But when it comes to like if their class is at 11 o'clock, they're testing. They don't have an option of waiting. Right? You know, if they come in like at 9 o'clock or 10 o'clock and they don't want to test, but I can't remember what the exact. Huh? They can test.
Then why do you make us wait?
I don't know exactly what the
He
circumstances
wanted
are,
us to
but
not test.
I don't know what the circumstances are, but if it was parts of their class, if you guys told me I want to test it in their class time, I have to test it first.
Even if you can tell them and they don't want to test it.
Well, I don't know what you guys are doing before then. Maybe you guys are practicing. I don't know. I don't know. Why you want to shoot me and kick me right now? I don't know. I can't remember what happened.
No, I'm just saying, like, if people want to test, why don't you just let them all test rather than, choose every one?
But that test was a longer. Obviously, it's a longer test. This test here shouldn't take more than 5 minutes. So I don't really give a damn when you guys come in for this one. You guys can come in and test whenever you want for this one. You guys want to come in early, okay? And I'm sure I've done that for a previous exam. It's just I don't know what the circumstances were last week, but
You want us to switch partners.
and I wanted to switch partners. Yeah.
Then everyone was, I think, just taking, moving off, they didn't really want to test.
Well, you know the problem is too is I don't like when you guys have the same partner because I've noticed people picking the same people, and you're getting, you know, some people are getting larger partners. Like let's say like Nick. Nick's not very easy dude to palpate, right? So here Alex and Nick are constantly partners, and Nick's like, damn, I like Alex because Alex is skinny, he's easy to palpate. Nick's like, Alex is like, damn it, man, why do I keep getting stuck with Nick? Right? So you see the issue, right? So it works out really well for some people. Some of you guys that are, larger dudes or larger women or whatever it may be are constantly picking these little twigs that are easy to palpate. And
Sometimes it's not that. You just get used to the person.
what's that?
Sometimes I don't. It's not about the skinnier. You just get used to the person.
I'm all.
Well, this is put it this way: being skinny helps.
It
right?
helps, but that's
It
not
helps.
why I have my.
If I were to put Nick on the table and tell you to go find his ASIS, and then put like Noe in the table and find his ASIS, I can guarantee it's going to be a lot easier to
True.
find his than
True.
Nick's. Right? So that's why I wanted people to break them up and not test with the same person.
So for the last one, you're just okay.
Yeah, this one here, I really don't care, man. It's just a 5 minutes. You be done and get it over with. 5 minutes, pops. There's 5 years.
Okay, show us.
5 years. It's not gonna hurt you. You got something to do, girl?
Well, you said it was 5 minutes. I want to see how fast 5 minutes is.
I didn't get it
What
done.
time you
I
took.
didn't get it done in less than 2 minutes. But there's five views, right? So some of the views I'm not even going to test you on. They're in your book, your test book, but I'm not going to test you on. Like a scout. You guys can do a scout. A scout for an IVP is a KUB. Easy money, right? Center at the crest. If you get a big person, a little wider, you're going to have to do two. Same thing. Nothing's changed, right? There's going to be a scout kidney shot, which I'm going to show you here in a second. So you got to do a kidney shot. And what else is there? The obliques. There's obliques. Obliques are the same thing as a lumbar spine, oblique lumbar spine. Same thing. You center at the crest, you go 2 inches medial from the ASIS. Same thing for an oblique lumbar spine. Only difference is you're at the crest versus a little higher. But same thing. Same thing, right? No big deal. And then there's some bladder shots. There's like an AP bladder, an oblique bladder, and a lateral bladder. So there's just a couple, there's 5 of them total that you guys will be responsible for. Okay, so it's going to be really quick. There's like 2 pages. One's an IVP, the other one's a system. The only problem with these is you obviously know that when you guys have such small exams, the more you miss, the more they hurt. Right? You miss two of them, you're already sitting like at 90%. So that's the only issue with these really itty-bitty exams. But they're pretty easy. All right, Serena, come here. I'm going to use you first, and then I'm going to switch them out. I'll put like noise on the table or something. Come here, girl. Come here, girl. Lie in the back.
Oh, sorry.
No shit, no.
Only got to tell her.
All right.
What am I doing?
You're going to lie down on your back.
Yeah.
All right. Next, ready.
No, what's babies?
Okay. So we're going to start with the kidney shot here. We get our tubes lined up and D10 and all that good stuff. This is the scalp. This is the scalp. So if you ever see like a nephrogram or it says kidney scalps or anything like that, we're just looking at the kidneys themselves. So if that's the case, we're going to use like 11 by 14 and go crosswise. Mascate 11 by 14. Okay? And that depends on your patient size. So if you have something that's small, you can get away
Crosswise
with using
or
like 10 by
portrait.
12 crosswise. Okay? So what you're going to do is basically we're just looking at the kidneys. And you can turn it right on.
Yeah, for the larger 11 by 14, 10 by 12 smaller patients.
Okay, so what we're doing is just looking at the kidneys, so a kidney scalp or a nephrogram. Okay? And the kidneys lie midway between the xiphoid tip and the iliac crest. So you don't have to go and palpate all that stuff. All you gotta do is find the top of the crest and put the bottom of the right top of the crest. Like that. Center midline. I think on midline. You got a good idea. You got
Yeah, you're
midline?
pretty damn midline.
And then you're gonna put a right marker in the lower right hand corner. Or you can use a left marker in the lower left hand corner.
Okay.
Okay? Simple as that.
So you said this is the EP one.
Kidney shots, or it might say like a scalp kidneys
Oh, okay.
or a nephrogram.
Oh.
Nephrogram is nephros kidney, right? So whatever it is, it's just the kidneys. Okay? I'm not going to show you a KUB or a scalp KUB because you guys know how to do that. And I'm not going to show you the obliques because basically it's an oblique lumbar spine. You just center at the crest, you go in 2 inches. Make sure you use a 14 by 17 for the obliques like this though. Use the whole image center. Just like that, and then you go 2 inches from the ASIS.
Okay.
Center at the crest. You guys have done all this stuff already, right? So I'm going to have you do one of those. Actually, I'm going to have you do the kidney shot, and then I'm going to have you do one oblique. I don't need to see both of them. You can do one, you can do the other one. I will on the obliques tell you which kidney I want to see. So if I say do an oblique that's going to show the left kidney and the right ureter, What are you gonna do?
RPO.
Good, okay, good enough. Okay, so then we're gonna go to the next page, is the cystogram. The bladder lies, most of the bladder lies posterior behind the symphysis pubis. So we're gonna angle 10 degrees. What that'll do is it'll take the symphysis pubis and let's say here's the bladder, and it's gonna throw it below the bladder. Okay, so it's gonna throw it out of the way. Make sure you don't forget to angle. Usually what I see is students fail to angle. You're gonna call them to like an 8 by 10, 10 by 12 in that area. Just kind of depends on your patient. And what you're gonna do is you're gonna find the ASIS, go down 1.5 inches to 2 inches, center midline. Right marker. Am I midline? Yeah?
Yeah.
Okay.
First seems true.
Easy breezy. Take the angle off, we're gonna do the obliques. Gonna roll away from that. That hair's bugging me too now. Keep looking at that hair. About a 45-degree oblique. Here's the ASIS. We're gonna go into and down to. All right, marker. So here's the ASIS.
Down now.
Into, down to. All right. Take this, go over to your left side. And then we're gonna do a lateral.
The marker was down now.
Oh, left side.
Your other left, girl. Come on. That's. I'm gonna take your arms and bring it back this way a little bit. And almost like doing a lateral sacrum coccyx. Make sure she's in a nice lateral position. Here's the ASIS right here. Go down 1.5 inches to 2 inches. Center midline. Mark it. Oops. Purple markers and green markers. Man. Messing me up. Center left marker and up high on the left anterior side.
You said
1.5 to 2 inches below the ASIS
and mid-coronal.
and mid-coronal plane.
And markers up and away.
And that's it. That's your test.
Easy.
That's the whole thing?
I hope I get home to them.
Dang.
Okay, Serena.
I'm confident.